Okay, this lecture is intended to introduce the lower extremity anatomy for first year medical students. That is the target audience. And we're going to review the bony structures of the hip, knee, and ankle, as foot as well. And that also includes the tendons, ligaments, muscles, nerves, arteries, veins, etc. We will sort of focus on the joints and some of the important structures, clinically relevant structures, and briefly talk about dislocation. First point here is just to point out that it is all connected, okay? Hip, knee, ankle, foot. Injury to the foot can cause biomechanical changes that can affect the knee or the hip and vice versa. Right hip pain can cause left knee pain, et cetera. And it is just important to remember that although this lecture breaks these down into separate entities, they are, of course, not separate. Anatomically, they cause problems for each other sometimes. So starting with the hip, we will start over here, and the simplest form is the head of the femur here. Okay, neck of the femur, the greater trochanter, the lesser trochanter, anterior and posterior view. Okay, probably the most important thing to point out here is the fovea here, which is for the ligament of the head of the femur and the artery of the head of the femur. Here's the acetabular cup, which is part of the ilium here, and it shows some of the ligamentous attachments. If you come down inferiorly, you can see the femur and the acetabulum are articulating, and then they show all the ligaments over the top that you need to know that help form the capsule. Unsurprisingly, they're named for where they start and where they go. So iliofemoral, ischiofemoral, pubofemoral, etc. Here's the pubofemoral ligament. Yeah, there's a bunch. I'm not going to go over all of them. For the med students out there, you just have to memorize this stuff. Here's a cross-sectional view of the head of the femur and the acetabulum here with the ligament of the head of the femur. Again, starting on the front here is nerve, femoral nerve, artery, vein, and a lymph node. It's important for anatomic reference, for orientation anteriorly, as well as sort of just clinical activity, whether you're putting a central line or an A line, femoral nerve block, or just things you have to avoid, generally speaking, for procedures and surgeries, etc. Here's the anterior structures of the hip, muscles of the hip, I should say. Basically includes the hip flexors, come over laterally, and you're starting to catch the external rotators and extensors. Here's glute max, and you're catching one of the adductors there. Here's the MRI correlate to that. I won't go over all of that, but it's a pretty good correlation to this illustration. The anatomy you have to know. So the femoral artery comes down in front of the hip here, as we saw on the previous slide. Some important parts of that, or branches of that, include the medial and lateral circumflex, which wrap around to the head and neck of the femur here and the trochanters. But perhaps more importantly is this little obturator artery and the branch here, artery to the head of the femur, which is super important. Probably the best example would be if you have a hip dislocation and the head of the femur is no longer articulating, this artery is either torn or under tension and compromises the blood flow to the head of the femur and sets you up for avascular necrosis, which is why time to reduction matters for hip dislocation. Thinking about the muscles as groups, this little clockwise illustration of the hip here helps make sense of that. The hip flexors are anteriorly, right? Hip extensors are posterior in the yellow and purple respectively here. The abductors are superior, and when they contract, they bring the hip out laterally. The adductors are inferior and medial, and they bring the hip to midline. And then there's external rotators here, which there's a bunch, the glutes. And then there's some more weak internal rotators here as well. The glute medius, probably the biggest muscle that does abduction, is a gluteal nerve innervation. Glute max is one of the extensors, also gluteal nerve innervation, so that all fits. Hamstrings get their innervations off the big sciatic nerve coming down from the lumbosacral plexus. The adductors are on the medial side, so they get the obturator nerve, and the hip flexor gets some of the lumbar branches of the anterior aspect of the lumbar plexus. The rest of these illustrations help map out what you're seeing on this sort of clock here, right? Anterior hip flexors, abductors, hip extensors in yellow, external rotators, and yeah, sorry, adductors down here. Abductors are superior, as well as the internal external rotators. And here is a MRI correlate of that, and then just a breakdown of all of this by muscle group. From a bony standpoint, if you know where the bones originate, sorry, if you know where the muscles originate on the bone and where they insert, you can pretty much figure out what the muscles do. As an example, on the front rim of the iliacus here, of the ilium here, you have the iliacus muscle, which comes down and inserts on the lesser trochanter here and does hip flexion primarily. And psoas muscle comes off the side of the lumbar spine here, and they come together to form the major hip flexors. On the inferior pubic rami here, you have all the adductors, which come down and attach on the medial side of the femur to do adduction. Posteriorly, you can see the hamstring attachments here, right? Biceps, semi-T, semi-M, and those are going to come down across the knee and then attach down here distally at the tibia and fibula. The external rotators are coming over here on the greater tuberosity, greater trochanter, excuse me. Those are some of the hip extensors and rotators there. They all originate on the back here of the ilium. And basically at the tensor fascia lata, you can see here, that's the big abductor here, and then it starts down here, okay, all the way down along the lateral knee. And then here's a cross section of that. So the anterior compartment is the quads. Quads do the most work. Quads have the biggest cross section, makes sense. Medial compartment, pretty small. Posterior compartment, pretty small, although a good athlete knows they need to work on their hamstring. So you can definitely make a bigger part of the cross section. And then just think of those as separate compartments. Okay? They are technically, but also sort of from a learning standpoint. The 65-year-old female presents with worsening hip pain over the last few years. She states it is worse with weight bearing and radiates to her groin, buttocks, and thigh. Pain sometimes occurs at night. There was no injury. What is the most likely diagnosis? Of these, hip osteoarthritis is the best. Skip this. So here is an illustration, sorry, a radiograph, PA radiograph of a normal hip. Here's the femoral head. Here's the acetabulum, and here's a beautiful joint space. This is normal. And then you come over here and you see something very, an obliteration of the joint space. The shape of the head of the femur is beginning to morph a little bit here. You see larger superior component here. You see some osteophytes forming on the acetabulum. You see some cystic looking structures, subchondral cysts, so bone cysts that occur from the microtrauma. See thickening of the head of the femur, thickening of the acetabulum. You know, see how this isn't really white over here? This is subchondral sclerosis. So again, the bone is thickening due to the bone-on-bone collision. This is a pretty profoundly arthritic hip that probably requires a hip replacement. So thinking through hip arthritis, number 2 behind the knee. Knee is number 1, hip is number 2, thumb CMC is number 3. Very common. Generally a primary problem, however, it can of course happen from trauma, hip dislocations, right? Inflammatory conditions, arthritis, psoriatic arthritis, congenital conditions like developmental dysplasia of the hip. Radiographs are sufficient. However, if for somebody with mild arthritis, not always so straightforward, do a very good history and physical exam to tease out what's causing their pain. Arthritis on an x-ray does not mean that that is the cause. People with mild arthritis typically do pretty good with conservative therapy. They may not have zero pain, but they can usually function. That can include education, exercise, activity modification, PT, weight loss, footwear, medications, corticosteroid injections, perhaps platelet-rich plasma, hyaluronic acid. And then operative indications are basically people who don't get better with that, who you know that it's coming from the hip, and then really severe cases just are not going to respond to conservative measures. And then this radiograph here is an example. Of course, there are many types of hip arthroplasty, but here's the acetabular component. Here's the head sitting in the acetabulum. Then it has a neck and a stem, stem that comes down into the shaft of the. Let's talk about some stuff on this slide. This girl's left leg is shortened and internally rotated. And you can see that correlates down here loosely with her hip dislocation. This is a posterior hip dislocation. Classically, these will present as shortened and internally rotated. And then here is a post reduction looking at least similar to her right leg. And then they have co-band or tied the legs together. And you can see she is rearticulating here. So this is just showing you what it looks like when it's dislocated. Over here, this older lady's right leg is shortened and externally rotated, and we will learn that that correlates with hip fractures. Okay, and that is because the greater trochanter, the hip external rotators are attached here. So when you break here, the tone of those externally rotates the hip. So it can occur at the head, neck, trochanteric or subtrochanteric. Think of this as a typical hip fracture. Acetabular fractures, femoral shaft fractures are different. Very, very common in the United States, one of the top expenses of Medicare, representing the vast majority of elderly fractures. Risk factors sort of correlate with age, osteoporosis, poor overall health, right? People who cannot stand up or sit down on their own, if you require a cane or a walker or a wheelchair, you are at much greater risk. Female, which goes back to osteoporosis, and then people who have frequent falls are obviously at increased risk. These patients typically do not require significant trauma. They have a lot of hip pain, worse with movement, and classically the limb is shortened and externally rotated due to the tone of the gluteal muscles externally rotating there. CT is sometimes needed for occult lesions or surgical planning, and almost all patients are surgical. You basically will not walk again without fixing this. There are some exceptions to that, and there are some patients who are just not good surgical candidates, and so those patients do not get surgery, but for the most part, everybody will. Here's your hip dislocation, okay? Much less common than shoulder, patella, finger dislocation. Think of a motor vehicle crash with the knee versus the dashboard, driving the femoral head behind the acetabulum, which is what you see here. Almost universally posterior. You can see it anteriorly with arthroplasty with an anterior approach. Lateral, pretty rare. Patients that have had a hip arthroplasty, it can be rather benign. For native hips, typically more violent. When it's posterior, it's almost always shortened and internally rotated like that old lady on that first slide. And you need to reduce these. Time to reduction matters. We talked about the blood flow to the head of the femur here, right? It's very tenuous. The longer that this femoral head sits outside the cup of the acetabulum, the increased risk of avascular necrosis. This is a patient with AVN here. You can see this crescent shape here, or maybe circular would be better. It is a complete collapse of the femoral head. It's integrating literally because it doesn't have good blood flow, and this patient is going to develop secondary osteoarthritis very quickly, or already is. And this is a famous football player who had a hip dislocation, had AVN, and whatever this. Trochanteric pain syndrome, very common, seen in middle-aged women, historically referred to as a bursitis. However, it really is not a bursopathy of any type. Sometimes it is, but much less commonly. More precisely, you call it a tendinopathy. All these gluteal tendons are coming over here and attaching along the greater trochanter. They do have bursa, however, they are rarely filled with fluid. Usually it's the tendon that is angry, so tendinopathy or tendinosis. However, all that said, a catch-all term used for this condition is trochanteric pain syndrome, widely accepted in medicine. How it happens, not really understood. Typically, some type of biomechanical dysfunction associated with an overuse or repetitive stress. Some of the other biomechanical problems can be lower back, IT band, hip arthritis, knee pathology. Diagnosis is primarily clinical, and that is going to be lateral hip pain, especially with tenderness along the greater trochanter. Management is non-surgical, including activity modification, physical therapy, NSAIDs, ice, weight loss. Patients are often obese. Trochanteric bursa, corticosteroid injections, shockwave therapy, platelet-rich plasma. And famously, this is a stubborn condition. Getting down to the anatomy of the knee, we have the medial condyle and the lateral condyle. Note the medial condyle is bigger. The articular surface of the patella, and then coming across and down here, you see the medial tibial plateau, lateral tibial plateau, and these two green ones represent the ACL and PCL attachments, respectively. Going back over here, now you have the meniscus on here. Medial meniscus, large. Lateral meniscus, smaller. both crescent shaped. See the ACL, anterior, posterior, ligament posterior. They've flipped the patella inferiorly or upside down. So you see the facets of the patella, which can be broken down regionally or geographically. And then here, same thing, they've disarticulated it. Now you see the meniscus from a sort of anterior point of view. You can also see the tibial collateral ligament, or MCL, and the fibular collateral ligament, or LCL. And those are the major structures on this side. And let's see here, you have the illustration of the horns, right? So there's an anterior and a posterior horn of each meniscus, okay? And depending on where the tear or injury is, how far it is from lateral to midline, also dictates to some extent what you do about it. Here's a good view of the ACL, anterior tibia, posterior femur, PCL, posterior tibia, and it's going to insert on the more anterior femur. And here's another illustration of that. And then the drawer sign, anterior, posterior drawer. So posterior, you're trying to translate the tibia posteriorly while the examiner is sitting on the foot. Not really pictured here, but you get the sense. And then anterior is the opposite. You're trying to pull the tibia towards the examiner, seeing if there's any laxity, and you have to compare these to the unaffected. Here is a medial view of the knee. So starting with the green stuff, you see the MCL attachment coming down here, okay? You see the pes anserine, you see semi-M, one of the hamstrings, you see the patellar ligament attachment to patellar tendon on the tibial tuberosity, the adductor, you see gastroc head. Here that is depicted more anatomically with the MCL coming down here, the pes anserine coming across. You see the gist of it. The lateral side, it's sort of a mirror image, although the fibula is now here. So you see the fibular collateral ligament here. You see Gerdy's tubercle for attachment of the IT band, IT tract, patellar tendon. See the lateral head of the gastroc, popliteus, the sad little muscle and tendon in the knee that unlocks the knee, but is associated with a lot of pathology, kind of a forgotten soul. And then here's your MC or LCL again. And then here's your, notably, your common fibular nerve sitting deep to the femoral biceps femoris tendon, which is vulnerable here for injury. Here's a sagittal view, a good sagittal view of the femur, tibia, and then you see the patella here, so your point of reference. Here's the quad tendon coming in, patellar tendon insertion down here. Here's the prepatellar bursa, which is associated with people who work on their knees, like carpet laying or housekeeper. There's a superficial and deep infrapatellar bursas here, which can sometimes be a problem. Office fat pad can be pathologic. This is the suprapatellar recess. This is really not a bursa. It is contiguous with the joint, right? So if somebody has an injury down here and their knee fills with joint fluid, hemarthrosis, infection, whatever, that fluid tends to collect up here. See the ACL and PCL kind of just half dissected out here. Posterior joint capsule, okay? And then here's a lateral view of that radiographically. I'll just point out here, you can see the suprapatellar bursa is filled with fluid here, suggesting there's a joint effusion. Here's an MRI version of that. So the quad muscles, femoral nerve, basically everything else in the leg coming down through the knee and distally is the sciatic nerve from a motor standpoint. Femoral nerve does have some cutaneous sensory components, but the hamstrings does all the motor stuff past the knee. So that sciatic nerve comes down, it bifurcates right here above the popliteal fossa, and you get the tibial nerve in the common. Okay. A 24-year-old basketball player presents to the clinic with knee pain. He states he was playing basketball, driving toward the basket. His knee buckled. There was no contact, and he felt a pop. On exam, his knee is effused, and he has a positive Lockman's test. The most likely injury here is ACL. Sorry about this. Not working. Here's Lockman's test. You're trying to translate the tibia anteriorly while supporting the proximal knee here. And then the drawer test, again, you're sitting on the foot, trying to translate the tibia anteriorly. You always have to compare it to the unaffected. Here's an MRI illustration of that. Here's nice linear fibers of the ACL, sagittal, and then you come over here and those fibers have been disrupted. You also note that there's a bunch of joint fluid here, hemarthrosis, also indicating the knee. Well, not noted over here. Here is so-called Segund fracture. Okay, this is associated with ACL tears. Anterior longitudinal ligament here that runs with the ACL that plucks that little piece of bone off. Typically, this is going to be a non-contact, sudden deceleration or changing direction type injury. Almost universally, there's a joint effusion unless it's subacute or chronic. The positive anterior drawers test, Lockman's test, Lever sign. Management generally requires reconstruction of the ACL. That can be done a variety of ways. That's a sort of moving goalpost as the literature expands. And then there's a role for prevention, which increases neuromuscular control and trains the hamstrings, calf muscle, etc. 24-year-old basketball player presents to the clinic with knee pain. He states he was playing basketball, pivoted on a planted foot. His knee is effused and he has a positive McMurray's test. This should clue you into meniscus tear. If I can get past this, it's okay. And so here's an MRI. I'll start here of the meniscus. So femoral condyle, tibia. This is probably the medial meniscus. Here's the anterior horn, nice little triangle. Posterior horn, nice little triangle. However, it has this lucency in the middle of it, which is indicative of a tear. It can be acute, as in the case of our patient here. It can be chronic and degenerative, which you can imagine can be managed differently. Diagnosis is a combination of MRI and clinical decision, or clinical exam. However, arthroscopy is the most sensitive, but not indicated in the vast majority of cases. In patients with chronic degenerative changes, not necessarily surgical. Some other reasons you may not operate as well. However, young active patients, typically with large tears, benefit from repair. Here are some of the special tests for the meniscus. The McMurray's involves palpating the medial and lateral meniscus, flexing and extending the knee with some internal external rotation and feeling for clicks. So you have to kind of show to understand. Here's Apley's compression, where you're making the patient prone and then driving their tibia into the menisci and kind of doing a grinding kind of maneuver. You can also distract it. Palpating the joint line is actually a pretty good test as well. And then Thessaly's is reportedly the most sensitive. I don't know that. I would say that, but the literature might. And the patient has their knee flexed about 30 degrees, and then they're doing some internal external rotation on that flexed knee. This same basketball player now presents to the clinic from basketball. He twisted his body on a planted foot. On exam, he has no effusion and is tender along the medial femoral condyle. This patient likely suffered a patellar subluxation or dislocation. Needed a drink of water there. Okay, this is an obvious one, at least in this particular presentation. Here's the patella sitting laterally to the femoral condyle. Here's the clinical correlation. This is a clinical diagnosis in this case. You can push on the patella immediately and extend the knee, and this should pop right back in. This is a very gratifying injury to treat. The lateral dislocation is far more common than anything else. Typically, non-contact twisting mechanism. Subluxation can occur probably just as commonly or more commonly than dislocation. The patient, if they dislocated, the exam is usually pretty obvious. If they subluxed, it is subtle. And one thing that can clue you in is tenderness along the medial femoral condyle and medial patellar pole here. And that ligament, the medial patellofemoral ligament, typically tears. So if the patella pops out here, that ligament must tear. Then tenderness along the distribution of that ligament is a good clue about what happened. That's why I said tender to palpation of the MPFL. And then any manipulation of the patella itself can also clue you into that. In the emergency department, we're going to reduce that and place that patient in a knee immobilizer. And then sort of more longitudinally, we're going to manage them non-surgically, assuming their x-rays otherwise look good, with NSAIDs, rest, patellar J brace, which literally forms a J, be a backwards J here, but around the patella to prevent it from sliding out, physical therapy, kinesiology tape. Patients with recurrence instability, right, it keeps happening. Some anatomic factors actually predict this and may need to be corrected, and then osteochondral defects and other lesions can require surgery. Here's some MRI stuff looking at the cartilage of the patella, articular cartilage of the patella. This is even listed as stage 1. I couldn't tell you what is wrong with this necessarily. However, this is early evidence of damage to the articular cartilage. Here you see some fissuring. The complete rupture here, and then this component is completely missing on this one. So it's just sort of a progression and MRI classification of chondromalacia, or breakdown of cartilage in the knee. This one could be considered an osteochondral defect, perhaps. You'll also note that there's a joint effusion in all 4 of these knees. Here you see lateralization of the patella more chronically. You see some osteophytes here. This is probably not an acute problem. You can imagine how painful that is. Same thing here on this lateral view where the patella is grinding along the anterior femur. Very painful. You see a bunch of osteophytes in the femorotibial space as well. Over here, we see what's called an osteochondral defect or osteochondritis dissecans. This can be congenital, which this spot typically is, or it can be traumatic, right, from patella dislocation. It's a bony cartilaginous defect that sometimes can pop off and be a real problem, and it can also cause pain here. You can see some inflammation. Okay. These are some causes of patellofemoral pain, which is typically considered a sort of diamond-shaped area of the anterior knee, which causes a lot of knee pain, right? So starting from the quad tendon down to the patellar tendon insertion here, including the patella and some of the structures around it. Think of it as a spectrum of disease, which is not well defined but commonly used. It represents the vast majority of knee pain. And here are some of the etiologies, right? Patella dislocation, we talked about, that's one, but any of the patellar sort of maltracking conditions, quad dysfunction, weak hip muscles and abductors, foot disorders, right? It is all connected. Hamstring imbalance, IT band, chondromalacia, we looked at those MRI pictures, osteochondral defect, extensor tendinopathy of the quad or patellar tendon, patellofemoral arthritis, we looked at an x-ray, right? These are all causes of anterior knee pain. Treatment somewhat depends on the etiology. However, a lot of it will be non-surgical. It includes NSAIDs, activity modification, physical therapy, bracing, injections, procedures. Rarely surgical, but some of this is. Osteochondral defect, for example. You just have a pebble rolling around in the knee. That probably needs to be dealt with. A 35-year-old male presents status post motor vehicle crash with multiple injuries, including a right midshaft tibia fracture. He has pain out of proportion to exam and with passive stretching of the ankle. He is unable to dorsiflex his ankle, and you suspect acute compartment syndrome, which is most likely affected. So the key is that he cannot dorsiflex. So the deep and superficial posterior are both responsible for plantar flexion primarily. The lateral is plantar flexion and eversion, and so the anterior is dorsiflexion primarily, and that would be the answer. So here are some pictures of a patient that could have acute compartment syndrome, or at least does. Here's a midshaft tibia fracture, which is comminuted, partially displaced, shortened. Here's a more proximal midshaft fibular fracture. Presumably this was a car accident. This is pretty violent. And here is an impressive looking leg. You can note that this has already been shaved down, so I would guess that this patient is in the operating room getting ready for fasciotomy. You see significant swelling and discoloration. You see bruising, and they have this lesion and they're in the OR. This is a good bet that this is about to get a fasciotomy. So acute compartment syndrome, the key here is understanding the deep and superficial perineal nerve in A and C, the two anterolateral compartments, and then the tibial nerve in the two posterior compartments. This can happen anywhere in the leg. This is where it is most common, related to tibial fractures. However, the anterior compartment is most commonly affected. The definition is when the pressure inside the compartment exceeds the ability of the body to perfuse the compartment, meaning that the amount of swelling in the anterior compartment is so profound that the arteriole down here, or artery, cannot push blood into this compartment. It can happen for a lot of reasons, of which midshaft tibia is most common, but vascular injuries, soft tissue injuries, crush injuries, snake bites, use of anticoagulation, a cast or splint which is too tight. There's a lot of reasons why it can happen, but trauma is the most common. Classically, the 6 Ps of compartment syndrome, which are, a few of them would be like poikilothermia, paralysis, pain, paresthesias, pulselessness, pain out of proportion to exam. However, what I will tell you as someone who's seen this, treated it, pain out of proportion to exam is your best bet. Pain with passive stretch. So if you just kind of wiggle their great toe and they freak out from their midshaft tibia fracture, that should be a clue. You can measure the compartment pressure. However, that is less often done, and more often a clinical decision is made. Treatment is with fasciotomy, and you can develop rhabdomyolysis, hyperkalemia, and multi-organ failure. More chronically, foot drop, right? So if you knock out the anterior compartment here, dorsiflexion is basically gone, and that patient's going to have foot drop. You can also have contractures, paralysis. Some people will lose their leg. Here's a smaller fasciotomy that has scarred down and healed as much as it can. It's supposed to look like this, right? That's the whole point. Here's an acute fasciotomy in the operating room, and you can just see the lateral compartment of the leg is just completely spilled out here. It's very impressive. Getting down to the ankle and foot, some anatomy here. So you have the tibia coming down, articulating with the talus. You have the fibula coming down, articulating with the talus to form the ankle joint. The interosseous membrane is here as well, stabilizing the whole thing. And then distal to that, you have, this is not the best anatomy page, but you have the calcaneus, you have the tarsal bones, metatarsals, and here's your radiographic correlates. We'll go over this view here on a different slide. What I want to point out here is C is the show part joint between the talus and calcaneus, and the cuboid and the navicular. And then the Lisfranc joint between the cuneiforms and the cuboid and the metatarsals. The Lisfranc joint we will talk about because it is associated with some catastrophic foot injuries. Here's some more x-ray pictures. You can pause this and read. MRI correlation here. Some of the soft tissue stuff you've got to know. The anterior talofibular ligament here, calcaneofibular ligament, posterior talofibular ligament, okay? The ATFL, the one that tends to get injured in a lateral ankle sprain first, and then followed by these two. Here is the Achilles tendon, worth pointing out. Here is the medial side, right? Here's the deltoid ligament. And then there's just a ton of other little ligaments you have to memorize that are part of this. Here's a disarticulated talus showing the talocalcaneal joint, which can be significant. This is another part of the calcaneus supporting the talus. This is the talonavicular, I think, and talocalcaneal joint here as well. Here is some soft tissue stuff. Looking at the lateral compartment here, you see the perineal muscle groups coming down under the retinaculum, starting on the fifth metatarsal and coming down inferiorly on the plantar surface of the foot. Then the anterior compartment also with retinaculum coming down to do foot and the toes. Go back to this. This is all the muscles and the innervations and sort of oriented by their activities. Will not get into them. 24-year-old soccer player presents with acute ankle pain. She states it rolled on another player's foot. She thinks it rolled in. She is tender on the lateral ankle. And which ligament is most likely injured? The answer is anterior talofibular ligament. Past this, there we go. So inversion ankle sprain. Auto ankle rules are useful to decide if you need x-ray, but an ankle sprain is primarily a clinical diagnosis. Tender along the ATFL. I like calf raise is a useful tool and watching them walk to determine the extent of their injury. You have to typically immobilize them in some form, whether it's a boot being the greatest immobilization or an air cast or lace-up ankle brace being the least. NSAIDs, IPT, rarely a surgical problem. Here we see a two-part ankle fracture, so so-called bimal fracture, okay? So here's the distal fibular fracture. Here's the, lateral malleolus is what I should say. Medial malleolus fracture. You can see the ankle looks unstable as the bony parts have disarticulated, and you can see the soft tissue deformity here. Typically, it can happen from a benign mechanism, and it can happen from a major mechanism. So you'll see these a lot. In the sort of acute phase, you're going to reduce them if they're not open. If they're open or, a neurovascular lesion that may go straight to the OR. But generally, you're going to reduce these and splint them. And they are almost universally surgical unless the patient can't or participate in recovery or is a poor surgical candidate. Here's some interesting imaging. So here is your isolated one-part lateral malleolus fracture. Doesn't look unstable here. However, you can see somebody's hand here. This is I think a thumb. Somebody is dorsiflexing the foot and stressing the ankle joint, and you can see the medial malleolus slides over more medially, indicating that despite this one-part fracture, the joint space is unstable, and this person will require surgery. Here, just to give you a more catastrophic example, you can see the complete dislocation of the tibia here, not articulating at all with the talus, essentially. This fibular fragment is sitting on the talus. Here's the lateral malleolus, not attached to the proximal fibular component. There's another piece of bone in the back here, which I'm not sure where that's coming from, but it's a pretty gnarly ankle fracture requiring reduction or will require surgery. A 44-year-old basketball player presents with acute ankle pain. He states he went up for a rebound and felt a pop in his ankle. On exam, his affected ankle does not plantar flex when the calf is squeezed. What is the tendon that is most likely injured? The answer is Achilles tendon. So here's an Achilles tendon rupture. So looking at the MRI in a sagittal view here, you see the proximal component and the distal component on the calc here. So this is a mid-substance tear. This is all blood. And you can see clearly on this one view that these are not articulating is the wrong word. They're not interfacing. Typically a middle-aged recreational athlete. So think about like a 40-year-old basketball player or soccer player, usually some type of violent dorsiflexion or a high-low impact from jumping. Patients will report feeling kicked in the back of their heel. Fluoroquinolones and steroids are classically associated with this injury. However, there are a lot of risk factors. Patients cannot plantar flex. They cannot push off. They'll have swelling and bruising and a positive Thompson test, which I'll show you. It's mostly a clinical diagnosis, but imaging helps confirm what you suspect. Management is almost always surgical. There is a non-operative protocol, especially for partial tears. So here's a good picture. This is the right limb with the foot resting in a slight plantar flexion. And here's the Achilles tendon rupture. See bruising, swelling. You don't really see the definition of the tendon. So here's the tendon right here. You don't see that over here. Could be just because of all the bruising and swelling. However, the most important thing is the resting tone of the left foot is on a more dorsiflexed position, and that is a big clue. And if you were to squeeze the calf here to evaluate the Achilles tendon, there would be no plantar flexion. If you squeeze the calf over here, this foot would plantar flex, and that is a Thompson. Up here, you see ultrasound of the Achilles and long axis. Okay, here is the distal component coming down and proximal component, and then here's a mid-substance tear. Okay, with some blood, hypoechoic fluid, which is blood here. This is a fifth metatarsal fracture, which can be broken down into avulsion fracture, zone 1, Jones fracture, zone 2, and stress fracture, zone 3. Essentially, the causes are anything that can cause an ankle sprain. Diagnosis is made radiographically. The auto ankle rules can help with that. If the patient is tender on the fifth metatarsal after an injury, that's an indication for an x-ray. The avulsion fractures typically do well without surgery. The Jones fractures are in a watershed vascular supply, so they may require fixation. And then zone 3 is a stress fracture, different sort of pathology and mechanism. Here's a better slide to explain these Jones fifth metatarsal fractures. So here is the zone 1 avulsion fracture. Note that it's articulating with the cuboid here. Probably okay without surgery. Here's a zone 2 so-called Jones fracture, not articulating with the cuboid in the watershed area, may require surgery. And then zone 3, you can see this just looks a lot different. The bone is thickened and sclerotic. It doesn't have a nice, clean, linear break. That's because this is a stress fracture. This probably doesn't require surgery. You just have to let it heal and stop running. Mechanism. Here's your Lisfranc ligament connecting the medial cuneiform to the proximal second metatarsal, which can be injured in a Lisfranc injury. Can range from a sprain to a dislocation. Can be fairly catastrophic. Usually a high energy direct trauma. An axial load on a plantar flexed foot, not food. Patient will have bruising, swelling, trouble ambulating. Diagnosis is radiographs. CT is often useful to better assess the bony injuries. Some patients can be managed non-operatively, but it's not very common. Usually this is a catastrophic injury. Here's some x-rays to help clinical and x-rays. So this is some bruising on the plantar foot, which you will see in a Lisfranc lesion. You can also see dorsal bruising. Here's a more subtle x-ray, not too subtle, but this is called a flex sign. So imagine the Lisfranc ligament going from the medial cuneiform to the second metatarsal. There's an injury, it plucks off a piece of bone. This is an avulsion injury called the flex sign. And then obviously over here, this is not, there's nothing subtle about this. This is a catastrophic Lisfranc fracture dislocation. This patient needs to go to OR. Second, third, and fourth metatarsals are broken here. I just noticed. This is just god awful disaster. Okay, plantar fasciitis, right? So here's the plantar fascia, just a ligament that connects the calcaneus to the distal forefoot, plantar foot, provides arch support. Okay. How does it get injured? How does it become a fasciitis or a fasciopathy? Not really well understood, but thought to be related to biomechanics and some chronic degenerative changes. The biggest clue that somebody has plantar fasciitis is when they get out of bed in the morning, they have increased pain that slowly gets better. This is very classic. And I just think of this as when you're asleep, the plantar fascia is not under tension. It contracts a little bit. And then when you get up in the morning and stand up, it is placed under tension, and that is painful. Point tenderness along the medial heel. So classically here, mostly a clinical diagnosis. Bone spurs radiographically do not equal plantar fasciitis. We'll discuss that. Treatment is activity modification, ice, heat, NSAIDs, physical therapy, orthotics, night splints, soft tissue treatments, injections, and very rarely surgery. Here's an x-ray of a heel spur. If you were to x-ray 100 people without any foot pain, a lot of them will have these, and they just simply don't correlate to developing plantar fasciitis. Here is an interesting x-ray. This is calcification of the plantar fascia. This is probably painful. This would be like having a bunch of rocks in your plantar fascia. Very painful. Here is a picture of the gait cycle. This is the final slide. I'm not going to get into it too much other than that first year medical students need to understand the gait cycle and left leg, right leg swing and stance.